Okay, so welcome to part 2 of chapter 15. Now, this figure 1520, brings together a lot of information we covered in part 1 of chapter 15. Starting at the bottom, we have the lub dub, right? The closing of the lub being the closing of the AV valves, right? Let's start that over again. 1, 2, 3, 6, 7, 8, 9. Welcome to part 2 of chapter 15. This figure, 15.20, provides a lot of summary of what's going on in the heart that we covered in the first part of chapter 15. Starting at the bottom, we have the sounds, the lub dub. The lub, the closing of the AV valves, right? That atrial ventricle valves, the tricuspid and the ventricle valves. The dub is the semilunar valves in the aorta and the pulmonary trunk, and they close with the dub. We move up and we can see the ECG, right, the electrocardiogram, and we have the waves, the P wave, the QRS wave, and the T wave, and that's going to correspond with the opening, with the relaxation and the contraction of the ventricles and the atria, and we go up to the ventricular volume, and you can see where the QRS wave, the stimulation, the depolarization, that's going to cause the ventricle to contract. And we can see that the wave hits first, and then we have that contraction happen, and the volume that the ventricle can hold reduces, and the blood is pushed out. And then it relaxes at the T wave, and the T wave starts the relaxation, and we get more volume, so blood enters it again. And then we move up to pressure changes, and that's going to correspond with all these changes as we contract and relax both the atria and the ventricles. So regulation of the cardiac cycle is done using something called, it starts at the SA node, called the sinoatrial node. This is going to control the activity, and we've covered this before, right, in part 1. Here, we're going to talk a little bit about things that are outside controlling it, influencing it, not controlling it and starting the wave that's going to cause the atria to contract and then having the ventricles contract, but things that are going to influence the amount of heartbeats per minute and the stroke volume, how much blood is pushed out every time the ventricle contracts. And things that are influencing it, not controlling it directly, but more like an influencer, is going to be there'll be some hormones potentially influencing it, but we also have the sympathetic and the parasympathetic neurons coming out of the central nervous system that can modify your heart rate in response to certain condition changes. Physical exercise is going to stimulate your heart to beat in a certain way. Body temperature changes are going to stimulate your heartbeat to modify itself in certain ways. Getting into a dangerous situation, stimulating a sympathetic nervous system to fight or flight is also going to cause a change in your heartbeat and maybe stroke volume. Also, diet, concentration of potassium or calcium in your heart is also going to modify heart rate. A parasympathetic impulses, right, carried by the vagus nerve out through so that's cranial nerve 10, is going to carry it to the SA and AV nodes and have your heart rate reduce, right? It's going to reduce your heart rate. Your sympathetic nervous system is going to send out commands to increase your heart rate, right? To pump harder and faster in response to maybe like a fight or flight situation. Both the parasympathetic impulses and the sympathetic impulses are going to the SA and the AV nodes. The sympathetic also goes through the ventricular myocardium muscle layer of your cardiac wall in the ventricles. Baroreceptor reflexes, right? So you have baroreceptors detect pressure, right? Like your blood pressure, and you have baroreceptors in your aorta and a few other places in your circulatory system. Baroreceptors are going to the reflexes from the baroreceptor are going to arise from the cardiac control center. So the baroreceptors report to a cardiac control center in your medulla oblongata. and it's going to balance both inhibitory and excitatory influence of the parasympathetic and the sympathetic fibers to make sure you maintain the blood pressure at the appropriate level for this said condition. So the baroreceptors are going to report and have us have a reflex to maintain the set point that we want. So the cardiac control center regulates the autonomic impulses to the heart, what information is going to the heart to modify and influence the heartbeat. If you remember the general reflex arc that we covered when we covered the nervous system, you have a receptor that reports to the central nervous system, and then we have to send out a motor neuron to influence an effector, a muscle or a gland. In this case, what we have is baroreceptors, and you can see that in the picture here. We have baroreceptors in the aortic arch, and we also have baroreceptors in the carotid artery. And they're going to report their information both to the medulla oblongata and to the hypothalamus, and we're going to send back motor commands to the AV and SA nodes, and that's how we control. As I said, the original pulse starts from the SA node, but there's influencing factors to modify rate of heart, how many heartbeats per minute, and stroke volume that comes out of the nervous system. And hormones can also influence a little bit. We have arrhythmias. Arrhythmias is an altered heartbeat, right? Heart rhythms. You get fibrillation, uncoordinated chaotic contractions in small areas of the myocardium. And we have atrial fibrillation, which so fibrillation in the aorta is not actually going to be that life-threatening, but if it's in the ventricles, it can be often fatal. So what is fibrillation? Chaotic contraction of small areas of that cardiac muscle tissue in the wall, in the myocardium. And if it's in the atria, it's not going to be, you want to maintain it with medical oversight. But if it's in the ventricle area, it can be often fatal, right? So even more medical intervention is required here. Tachycardia is abnormally high heartbeat, greater than 100 beats per minute. When at rest, when you're sitting there relaxed, your heart is going at 100 beats or more. Bradycardia is a slow heartbeat, less than 60 beats per minute when at rest. Flutter is a rapid, regular contraction of the heart at a high rate, 250 to 300 beats per minute. That's really, really high. That's a flutter. Premature beat is a beat that occurs before the expected occurrence in the normal cardiac zone. So the rhythm is off, right? You have a beat, that is not happening at the right moment, and that's often because there's a contraction happening in a region not stimulated by the SA node. You have kind of like a weird apoptotic region of the heart contracts on its own. And an apoptotic pacemaker, interesting enough, you have a backup to your SA node. As I said before, the SA node controls, the start of your contraction, right? You contract the atria first, and then it goes to the message goes to the AV node, and then it continues down the ventricles, as I covered before. But interesting enough, if you, for some reason, toxins, a little ischemic event, you have the SA node becoming damaged, the AV node can actually take over and cause this to happen and have your heart run and keep your life going. It doesn't do it as well, right? If the AV node is taking over, acting as a secondary pacemaker, it's going to beat 40 to 60 times per minute instead of the 70 to 80 times per minute. And of course, you know that if things get really off, you have the opportunity, if you need, to get an artificial pacemaker placed to replace your SA node. And it's implanted, and it's battery powered, and can often be a problem when you're going near things like microwaves and things like this. Moving on to blood vessels. Blood vessels are the organs of the cardiovascular system, right? They are part of the cardiovascular system that is not your heart, right? So I'm moving on to these. They form a closed circuit, right? So your blood vessels are closed, and they, like a racetrack is closed, right? You don't have gaps in it where the blood will spill out into tissues directly. You filter things into the tissues. through pores and diffusion, and we'll get into that in a few slides. But blood vessels are a closed circuit transporting blood from the heart to the body or from the heart to the lungs and back to the heart. And we have, and we've kind of lightly talked about them already, these type of blood vessels. We have arteries. Arteries always carry blood away from the heart, even if it's in the pulmonary circuit, if it's in the systemic circuit, it's carrying blood away from the heart. Arterioles, when you get down through the large arteries, they're going to get smaller and branch a little more and get smaller, and they're still going to be artery-like in their construction until they get to the really end, and they're called arterioles. Their walls are a little thinner. They're going to receive the blood from the arteries and carry them to the capillaries. The capillary beds, right? We have a lot of networks going through the tissues of capillaries to feed the cells that are present. Capillaries are the site where we do the main thing, right? We do the exchange of substances. We, in our body, give oxygen and nutrients to the tissues, and we take up their waste. When we get to the lungs, we throw off CO2 into the lungs so it can go away, and we bring in oxygen. So that's what the capillaries are for. Now, the capillaries are going to take the blood that has been used and pass them on to venules, small vein-like blood vessels. So they're going to receive the blood from the capillaries, and then they're going to feed the blood to the veins, and the veins are going to carry it back to the atria of the heart. If it's coming back from the systemic circuit, it's going to carry blood back to the right atria, and if it's coming back from the pulmonary circuit, the veins are going to carry it back to the left atria. So if you look here, we have two blood vessels. We have the artery and the veins. The arteries have thick walls. You can see that right there. There's an eyeball between the two. The arteries have thick walls. And part of that is to both maintain and deal with the blood pressure. Because remember, the arteries carry the blood away from the heart. So the blood coming out of the heart is going to be under pressure as the ventricles contract. We have the outer layer called the tunica externa, and that's going to have collagen. It's basically connective tissue providing shape and protection to the blood vessels. Middle layer is going to be the smooth muscle, and it's called the tunica media. Then you might have a little layer of connective tissue as a backing for what is the inner layer, and it's going to be epithelial tissue, right? And it's usually simple squamous epithelium. And this is the tunica interna. Now, one word you might want to see here and highlight is lumen. What is the lumen? Well, let's say you take a piece of, plumbing pipe, and you look down the pipe. The hollow area inside the pipe is the lumen of the pipe. The lumen of the artery is the hollow area in the center of the artery that the blood is going to pass through. The hollow area of the vein, right, is the lumen of the vein. So if we look between the vein and the artery, what is common? Well, they both have that tunica externa to provide shape and kind of like some protection and rigidity, right? Some, kind of like structure. We have smooth muscle in the middle, even though the artery has a lot more of it. And then we have an internal lining. The walls of the artery are going to be thicker, right? Because they have much more of that muscle, that smooth muscle in it. The vein has a bigger lumen than the artery. It also has valves, and we'll get into why it has valves a little down the road. Okay, so angiogenesis is formation of new blood vessels. Now, we do a lot of it when we're developing as a fetus, but we also have things like cancer, right? When a tumor is developing, it wouldn't grow very big if it had to rely on diffusion. It can't, but we do get big tumors sometimes, if you're ill, and that's because tumors are going to secrete a hormone, well, not a hormone, but a chemical called VEGF, vascular endothelial growth factor. And this is going to stimulate new growth of blood vessels. And this happens a lot, normally when we are developing. We have angiogenesis is regulated by the body, since excessive, deficient, or inappropriate blood vessel formation is common as a cause for common diseases that we've talked about, like cancer already. But we also have need for it in our normal life, like things that are going to promote angiogenesis. The body will secrete VEGF in response to a blocked artery, let's say a coronary artery, or other types of blockages in our circulatory system, and we might actually grow a pathway around it. If it's not sufficient, you can medically take additional VEGF in tiny release capsules to help us potentially solve the problem by growing some more blood vessel or fixing that blood vessel by stimulation of this chemical. Why would you prevent angiogenesis? Well, I mentioned the fact that tumors will secrete VEGF to get a circulatory system to feed the tumor. Now, if we put anti-angiogenesis drugs inside a person suffering from tumors, that's going to cut off the ability of these new tumors to grow, arterioles and capillaries to feed it, and then potentially we can prevent further development of this tumor. Right? It's also useful in macular degeneration. So arteries, a little more specific, are the thick-walled one. They have 3 layers, like we talked about. The most inner layer is hopefully smooth, right? It's going to be some type of epithelial tissue, usually simple squamous epithelium. And that's the tunica interna, right? And then we have the smooth muscle layer with some elastic tissue connected to it, and that's the tunica media. That's the mid area of the wall of the artery. And then the outside layer, which in this picture is the white area, and that's the tunica externa, right? That's connective tissue with collagen fibers. This is having a thick wall to both transport blood under high pressure, right? It has to deal with all that pressure so it doesn't rupture. It also maintains the pressure. We want that pressure to be maintained to help us move the blood through. When it gets further along in the body and we have to go and spread out to different tissues, the arteries gets a little smaller and a little smaller, and eventually they become arterioles, right? They're a smaller version of the arteries that will feed into the capillaries. Arterioles are thinner walled than the arteries, not a surprise. They're smaller. The walls of the middle and the outer layers of the wall become thinner as they become smaller. We start getting less and less of this muscle in there. Both arteries and arterioles can undergo vasoconstriction and dilation. So when we keep on talking about, our blood vessels dilating and constricting in our, like the dermis of the skin and other areas, this is a place, the arterioles and the arteries are one of those things that are controlled. If you look here, we're down at the arterioles. When it gets this low, we only have a few muscle fibers in that middle layer, right? And you can see like individual smooth muscle cells doing simple jobs now when we get down to this layer where we're just about to feed to the capillary bed. And what's going to eventually, this is mentioned in a moment, the precapillary sphincter is a smooth muscle right at the start of the capillary that's going to help us control the flow into the capillary from the arteriole. So the capillaries are the smallest diameter blood vessels, and they're going to come out of the smallest types of arterioles, and the blood's going to go through the capillary, and then they're going to connect up to the smallest type of venules, right? Small vein-like blood vessels. Really, they're extensions of the inner lining of the arterioles, which is what? Simple squamous epithelium. Right? And they are semi-permeable. They're going to allow certain things to go into the tissues that surround the capillary and take in things from the capillaries, but not everything, right? Remember, things like an example, the albumins stay in the plasma in the blood. They don't go out into the tissues. Capillary blood flow is regulated by the precapillary sphincter. I pointed that in the last picture, right? And there we go. So how do capillaries work? The structure of them and the permeability of them. Well, we mentioned that they're made of epithelial tissue, made of the thinnest type of tissue we have, simple squamous, one layer flat tissue, right? Substances are exchanged by diffusion, right? There's pressure, so there's a little filtration actually going on. opening in the walls of the capillaries are thin slits, and you can see that in the picture here, right? You can see in the lower picture, you can see that passageway between the cells that allow the thin slit to allow diffusion to happen. This is where the epithelial cells are going to overlie each other. The sizes are going to vary depending upon what type of tissue it's in, and permeability is going to vary with the size of that slit between the areas, between the cells. And you can see that in the picture above there. Fluid, the tissue fluid, what they're talking about is the interstitial fluid there, the fluid between the cells. And we're going to have fluid come out of the blood into the interstitial fluid, the fluid between the cells there. And then they can exchange with the cells by diffusion. You can see here a nice arrangement. The arteriole is that big red stick-looking thing, pipe-looking thing in the upper right corner. And then it's passing blood into the capillaries. Notice that it starts in red in the capillaries, but then they become blue. That's the blood inside the capillaries turning from oxygenated to deoxygenated blood, right? As it gives up oxygen and nutrients to the tissue around it. When it gets to the other side, it's going to be picked up by a venule that's going to carry it off to the vein, to a vein. Tissues with lower metabolic rates, such as cartilage, don't have that many capillaries, but areas that do have a lot amount of metabolic activity, like muscle areas, are going to have a lot more capillaries. Right? So muscle and nervous tissue have a lot of capillaries to feed it so that they can get all that oxygen to provide energy and the nutrients to have physiology going on at a high rate. And areas that are kind of more sedate, like cartilage, right, which has a lot of extracellular matrix, and the chondrocytes just maintaining the tissue, are going to have fewer. Capillary exchange. Capillaries are going to exchange what? What do we exchange with capillary? We're going to exchange gases, nutrients, metabolic byproducts, take in waste from metabolic reactions like CO2. And the process of this exchange is by one, diffusion, and that's the most important method of transfer. Remember, by the way, that things that are like lipid-loving substances can pass through membrane walls easily because what makes the wall? Phospholipids, and that's going to be allow anything that likes lipid to just pass through the cells. Water-soluble things can pass through the slits between the cells and get into that area through carriers and canals in the membrane, right, to get into the cell and so forth. That would be facilitated diffusion. Remember facilitated diffusion? So that would be an example of that. Water-soluble things will do it now. Filtration is under hydrostatic pressure. That's the pressure from basically your blood pressure. It's going to force molecules through some of those membranes. And the pressure is also derived from ventricular contraction. Well, that's the ventricle of the heart contracting, providing blood pressure. We'll get into blood pressure in a few slides. Osmosis is also going to play an important part. We're going to see this much more in the next detail, right? So let me actually do the next slide. So let me show you the next slide. So that blood on the right side, that's red, flowing into the pipe, that's the main part of this picture. That is the arteriole. And the one pipe here is representing a capillary bed. And then on the other side, we have a venule to carry it off to the veins. When the blood is coming in at the start of the capillary bed, the hydrostatic pressure is roughly around 35 millimeters of mercury, right? So that's the pressure level. And the osmotic pressure is actually to pull things from the tissue, usually interstitial fluid and such, back into the capillary, So we have two opposing forces: pressure to push the fluid out, the plasma out, and osmotic pressure to bring the interstitial fluid in. On the side closer towards the arteriole, the balance is in the favor of the hydrostatic pressure. Matter of fact, like here in this picture, it's 11 millimeters of mercury outward pressure. So we have a force overall, a net force of 11 millimeters of mercury to push fluid out of the capillary, carrying nutrients and oxygen and such. When we head towards the end of the capillary bed, now the osmotic pressure is still 24, but the outward hydrostatic pressure, because remember, we're going through the capillary bed and it's branching and it's branching again, and you have capillaries, and you have less pressure as we get further and further along. The hydrostatic pressure now is 16. So the osmotic pressure is stronger than the hydrostatic pressure, in this case, by 8 millimeters of mercury. So fluid from the tissue is going to come back into the capillary. So at the arterial end of the capillary, the hydrostatic pressure is greater than the osmotic pressure. So water and other substances leave the capillaries. And at the ventricular end, right, near the venule, we're going to have the osmotic pressure being greater than the hydrostatic pressure, the blood pressure area. The water is going to be carried back into the capillary, carrying with it waste and so forth. Anything else about that? Okay. Oh, what is maintaining the osmotic pressure? We mentioned this in the blood. Remember albumins and some of the globulins, right? These large proteins that are floating around in the plasma. That's one of their big jobs is to maintain osmotic pressure so that it brings the water back in as we head towards the end of the capillary bed. If we didn't do this, by the way, you would end up, your blood would start getting thicker and thicker as you lose more and more water to the tissues, right? We wouldn't carry the waste away, and the tissues would gather more and more water and suffer something called edema as the tissues swell because the fluid is hanging out in the tissues as opposed to coming back into the blood. Venules is a microscopic vessel, blood vessel, that transports blood from the capillaries back to the veins. They're thinner walled than both the veins and the arteries and the arterioles. Less smooth muscle, right, than the arterioles. Remember that we saw that when we compared the arteries and the veins, the arteries had more smooth muscle in the middle of the vessel wall than the veins. And this is true for their smaller components. The venules have less smooth muscle than the arterioles. When we get to the veins, right, the walls are thinner than arteries. They have the same 3 layers, right? They have the tunica externa, which is the connective tissue layer, the tunica media, and then we have the epithelial layer on the inside. The tunica media that has the muscle layer is less developed than the artery one. And it's going to carry blood under fairly low pressure in comparison to the artery. And that's one reason that it doesn't have to have that thick of a wall. It functions as a blood reservoir. This is a kind of an interesting and important point. Most of your blood at any given moment is sitting in veins. So we'll see a graph of this in a second, but your blood is going to act as a reservoir, a pooling area for your blood. It's not truly pooled and like it's staying stagnant, but this is where most of your blood is at any given moment. They also have flap-like valves, and the reason they have that is because there's such low pressure in your veins in comparison to the arteries. We don't want any backflow. So as we move blood along in the veins, we don't want any backflow if it kind of gets, the blood pressure gets a little too low. So here's blood vessel characteristics and distribution, blood distribution in them. In your systemic veins, you have 60 to 70% of all of your blood. That's 2/3 of your blood sitting in the systemic veins. Your lungs have about 10%, your heart about 10%. Your systemic arteries about 10%, and then your capillaries will have about 5% at any given moment. Summary of everything we just went through, good to study with. So remember, when you're studying for the test, you can look at these as a summary. Blood vessel disorders. Atherosclerosis is a deposit of cholesterol plaque on the inner lining of the walls of the arteries. We mentioned if this builds up too much, it's going to block the passageway of blood, and you can suffer heart attacks and other types of ischemic events. You can also start throwing clots. You can provide a place for intrinsic clot formation, right? And then you have an aneurysm, which is a bulge in the wall of an artery when pressure dilates a weakened area. And if this actually bursts, you can actually have an aneurysm where it bursts and the blood leaks into tissues, and of course you can have a life-threatening event this way. Phlebitis is not usually a life-threatening event. It's just inflammation of a vein that can be very annoying. Varicose veins is abnormal and irregular dilation of veins near the surface of your body, right? Superficial veins, close to the skin or in the skin. Most common in legs, and pregnant women can suffer from this fairly often. Moving on to blood pressure. So that's the force being exerted against the inner walls of any of the blood vessels. But when we really talk about blood pressure, we're really talking about the pressure in the systemic arteries, the arteries that are carrying blood out of the left ventricle and passing in through the systemic circuit. So not the purpose, but one of the things that's going to circulate blood, right? What circulates blood through your body is the blood pressure. There is blood pressure throughout the vascular system, and we're going to go see a chart on how it changes in the different areas, right? Between, the systemic arteries versus the arterioles versus the capillaries versus the venules versus the veins. And remember, blood is, when anything under pressure is going to want to move from high pressure to low pressure. Okay, so arterial blood pressure rises when the ventricles contract and will fall when they relax. Measuring the pressure, right, let's say in your aorta, right, in your arteries, when the ventricle contracts, that would be the systolic pressure. Remember, systolic means contraction. So systolic pressure is the maximum pressure reached when you have a ventricular contraction. Diastolic pressure, right, is going to be the minimum pressure that we can achieve when the ventricles are relaxed, right? The lowest point that we hit. And this is when the ventricles are relaxed. Pulse pressure is the difference between your systolic and diastolic blood pressure. So it's SP, systolic pressure, minus DP, diastolic pressure. MAP is the mean arterial pressure, and it's the average pressure in the systemic arteries, right, the arterial system, representing an average force driving the blood to the tissues. So that would be diastolic pressure plus 1/3 of the pulse pressure. And that's how you achieve that. Usually when you're talking about blood pressure, you all have probably heard this before. It's usually stated as a fraction with systolic pressure over diastolic pressure. 120/80, that's kind of like the average blood pressure, the average healthy blood pressure that people state. And when they say 120/80, that's presumed to be in millimeters of mercury. That's what's being measured. That's the unit for the pressure. Arterial blood pressure is usually measured with a device, as you see in this picture. Some of you have probably done this a lot. Some of you might be newly exposed to it. And when we get back into the school, you get to start playing with this. And I'm going to mess it up because this is the type of the long word that I kind of mess up when I say it. Sphygmomanometer. Okay, let me try that again. Sphygmomanometer. There you go. Now, as I said, as we go through the arteries and through the whole blood vessel circuit from out of the heart back to the heart, the pressure is going to change. So at any given moment, the aorta is going to have the largest difference, right, between the systolic and the diastolic pressure, and both of those values are going to be pretty high, right? So here we have 120/80 as a blood pressure going on, and the values are fairly That would be traditional. That's a normal blood pressure. Systolic, remember, is the pressure when the ventricle is contracted. Diastolic is when the ventricle has relaxed and we have achieved the lowest pressure. And so the separation here is pretty large. When we go to the large arteries in the body, right, coming off of the aorta, like the renal artery or the femoral artery or something like that, we're going to have a little bit of a dive in the pressure going on, especially at the systolic. The diastolic might maintain a little bit. The gap gets a little closer. Then we get to the small arteries and the arterioles. The pressures are beginning to dive, and they're getting closer as we get to the smaller and smaller blood vessels. Now, remember, when we get to the smaller and smaller blood vessels, we're actually increasing, we have a few large arteries, a few more small arteries. The arterioles, we have much more than the small arteries. And the capillaries, we have capillary beds, so we have all this piping. And that's part of the reason for the blood pressure declining. When we get to the capillaries, the separation between the systolic and the diastolic is minimal, non-existent. You could probably measure a slight difference if you went in there with really fine equipment, but for our purposes, it's basically not there. And it's hovering in the middle right there around 20 millimeters of mercury. And then when we come out of the capillary bed, we're even lower in the venules. And then when we get to the small veins and the large veins, it dives even lower and lower. And then eventually goes to the vena cava and pours into the right atria if it's coming back from the systemic circuit. If it's coming back from the pulmonary circuit, it will go into the left atria. So sites for measuring, good sites for measuring arterial pulse. You can use the following places: the temporal artery up here near the ear, carotid artery in the neck, the facial artery kind of positioned underneath the jaw. You have the brachial artery in the elbow and the radial artery in the wrist. You have the femoral artery on the inside of the thigh, and the popliteal artery on the back of the knee, the dorsalis pedeus artery on the ankle and in the front of the ankle, the posterior tibial artery at the back near the Achilles tendon. Factors that influence arterial blood pressure. So we have blood pressure increasing if we do the following things. If blood volume increases, if we have more blood in the same we don't have any more area to put it, that's going to increase blood pressure. So if we increase blood volume, we increase blood pressure. If the heart rate increases, right, if we pump more often, we're going to increase blood pressure. If we increase how much we send every time the heart beats out of the ventricles, that stroke volume, we're going to increase blood pressure. If the blood becomes more viscous, now what is viscosity, right? That's the inability of the fluid to move smoothly, right? Things are bumping into each other and so forth. If we have rough walls, that would increase the viscosity, the peripheral, that's peripheral resistance. Blood viscosity. The best way to think about it is to compare water. Water is not very viscous. It moves very nicely and easily. But if I compared it to the movement of maple syrup or motor oil, they move a lot more slowly. And that's because of the viscosity of it. If you have high blood viscosity, blood pressure will also increase. Peripheral resistance, right? That's when we have things like rough walls that is going to prevent the blood from flowing easily. We'll get more into that. There's a slide coming up. But all these influences would increase blood pressure. Stroke volume, SV, right? So the amount that is normally sent out with one beat is roughly around 70 millimeters of, okay? So that's if my ventricles contract, 70 millimeters of blood are going to go up into the aorta and the pulmonary pump. Cardiac output, right, is how much blood is discharged from each ventricle, from a ventricle each minute, right? So it's the amount of blood put out each minute from a ventricle. In this equation, CO is cardiac output. This is going to be the stroke volume times the heart rate. How many beats per minute? Right? That kind of makes sense, right? If you're measuring how much blood is moving in out of the ventricle in a minute, you have to take stroke volume times heart rate, So if we use the normal numbers, cardiac output, then normal stroke volume is 70 millimeters per beat, and we have 72 beats per minute, and we come up with 5,040 milliliters of blood per minute. Blood pressure varies with cardiac output. So if we increase the cardiac output, we're going to increase blood pressure. If we decrease cardiac output, we're going to decrease blood pressure. Now, if we increase one or the other or both of these, we're going to increase our blood pressure because we're increasing cardiac output. So if we increase stroke volume, how much we put out with each contraction of the ventricle, we're going to increase cardiac output, which increases blood pressure. Or if we increase how many beats per minute are happening for the heart, we're going to increase cardiac output, which is also going to increase blood pressure. Okay, so blood volume. This is, the sum of all the plasma and the formed elements. This is going to vary both with age, body size, and gender. 5 millimeters of blood for most adults. It's a little less in females, a little more in males, so that was an average. 4 to 5 liters in females, 5 to 6 liters in males, and that's more or less probably in proportion to the usual height differences between males and females. Blood, if you poured it out, takes about 8% of your overall body weight. Blood pressure is directly proportional to blood volume, as I said. So if you're a female who has a higher amount of, or a male who has higher amount of blood, liters of blood, for your given size, you're going to have a higher blood pressure than someone your size. So any factor that changes blood volume can change blood pressure. If you start losing blood, you have a big laceration, a big cut, and blood is pouring out. That's reducing your blood volume. That's going to change your blood pressure. We'll do so for other reasons too, but that's an example. Oh, yeah, due to a hemorrhage will decrease blood pressure. I mentioned that we were going to talk about peripheral resistance. Peripheral resistance is the force of friction between the blood and the walls of the blood vessels. And it's kind of like a thing that is going to have to be overcome that peripheral resistance to allow flow. If by banging in the walls stop the blood, we'd have a lot more decreased flow. Right? So we have to have pressure, blood pressure enough to overcome that peripheral resistance. Factors that change the peripheral resistance will also change your blood pressure. Vasoconstriction of the arterioles, remember we can constrict and dilate the arterioles, we are going to increase peripheral resistance when they get tighter, right? That's going to make the blood hit the walls much more often as it goes through the pipe. And that's going to increase blood pressure. When blood is pumped out of the ventricles, the arteries are going to swell and then they're going to retract, they're going to contract in like an elastic recoil. They swell and grab and come back, right? That's going to be that smooth muscle grabbing in the wall and contracting. And that's going to send blood through the arteries against the peripheral resistance in the capillaries and the arterioles. So that rapid recoil is going to add a little oomph to that push against the peripheral resistance. Viscosity, which is the difficulty for water for molecules to flow past each other. It's really easy for water to flow past each other. It's really hard for maple syrup and oil to have their molecules past each other. The greater viscosity, the greater resistance to blood flow, right? More blood cells, more plasma proteins like albumins and globulins are going to increase the blood viscosity. The greater resistance to flow, then greater the force necessary to push the blood, the greater the blood pressure becomes. Any factor that alters the blood concentration of red blood cells, let's say, or albumins or globulins, the plasma proteins, will also alter the blood viscosity. Anemia, where you have low levels of red blood cells, are going to lower blood viscosity, which is going to lower blood pressure. Okay. Control of blood pressure. So blood pressure is determined by cardiac output, as we determined a few slides ago, and peripheral resistance. So peripheral resistance, so overall blood pressure, cardiac output times peripheral resistance. So you can see how when we talked about cardiac output influencing blood pressure, here we come down to the final step where we combine it. Cardiac output times peripheral resistance gives you that blood pressure. Maintenance of blood pressure requires regulation in two different directions, right? We have this, we've seen a lot of these figure 8 homeostatic control mechanisms presented to you. So normal blood pressure is roughly around 120/80. If it gets too high, baroreceptors in the aorta and the carotid artery are going to detect that and report it to the hypothalamus. And it's going to, if it's outside the set point, if it's too high, it's going to send out commands through motor neurons, right, to tell the blood vessels, the arterioles, right, and arteries, to decrease resistance, right? We want the blood pressure to go down, so they're going to dilate and allow more easy blood flow to go through and decrease the PR, the peripheral resistance. We're also going to tell the heart to decrease how many times it's beating per minute, and decrease stroke volume, how much blood is coming up. Sometimes they'll just modify one or the other, or do both at the same time. All this is going to decrease cardiac output, which is going to bring our blood pressure back to normal, decreasing peripheral resistance and decreasing cardiac output. If our blood pressure is too low, the baroreceptors in our aorta and carotid artery are going to detect that. Remember, baroreceptors mean pressure receptors. And the hypothalamus is going to be stimulated, the autonomic nervous system, right, in the hypothalamus, to tell our effectors to increase blood pressure. And how does it do so? Well, the smooth muscle in our arterioles and arteries are going to be told to constrict, right? And that's going to increase PR, peripheral resistance, and that's going to raise our blood pressure. And our heart rate is going to be told to increase, and our stroke volume told to increase. And that's going to increase cardiac output. So here in the blood vessels, we are telling the PR to increase, and in our heart, we're telling it to increase cardiac output. Just like when it's too high, we told the blood vessels to decrease peripheral resistance, and tell the heart to decrease heart rate and stroke volume, which is going to decrease cardiac output. So here's kind of the two different, here we have one dealing with the heart and one dealing with the blood vessels. So over on the left side, we have cardiac output for some reason has increased, and our blood pressure is increased. Our baroreceptors in the aortic and the carotid sinuses are stimulated. The sensory impulses from the baroreceptors, right, are going to be carried from sensory neurons into the cardiac center, where the parasympathetic impulses to the heart are going to be told what's going on. Okay, let me rephrase that. So we're going to carry that information to the cardiac center. The cardiac center is going to compare it to the set point, say, oh, this is too high, and we're going to send commands out to the parasympathetic nervous system to the heart, where the SA node is inhibited. We're going to reduce the beats per minute. The heart rate decreases, and our blood pressure returns to normal. So here's an example of how we're returning blood pressure back to normal by controlling the heart a little bit. And over here on the right side, our blood pressure has risen. We have the same baroreceptors detecting this change. And so at the same time, we're going to have sensory impulses going to the vasomotor center, not the cardiac center, but the vasomotor center, the ones that control the blood vessels. And the vasomotor center is going to be comparing it to the set point and say, okay, we need to change this. And we're going to send out less frequent stimulation to the arterial walls, right? And that's going to cause dilation of the arterioles. And we're going to decrease peripheral resistance, and that's going to reduce our blood pressure back. Hypertension is high blood pressure. The long-lasting condition, right? Just a brief increase in blood pressure is not going to be a condition, but if it's a long situation for you, then it becomes hypertension. And this is arterial blood pressure, of course. Causes sometimes unknown. If you take too much salt continually in your diet, you need to reduce that, or you can suffer hypertension. Prolonged psychological stress that activates the nervous system can lead to situations with hypertension. Obesity is going to increase peripheral resistance, which will increase your blood pressure. Kidney disease, right, is also going to cause problems with your renin-angiotensin system. We'll learn more about that when we get to the urinary system. And we'll get a little more into blood pressure control there too. Silent killer, because you may not have any symptoms for a long time that you have hypertension. When you have hypertension, you can increase your risk of developing atherosclerosis. As we mentioned when I mentioned atherosclerosis before in this chapter, it also can lead to the formation of a clot, like a thrombosis or an embolism in the area. And then the embolism is when it breaks off from it. May lead to cerebral thrombosis, embolism, or hemorrhage, and that can result in something called a mini stroke, a TIA, which is a transient ischemic attack, which can do damage to your neural tissue in your brain, or a CVA, cerebral vascular accident, in other words, a stroke. Usual prevention for this is some decent healthy diet, exercising, and limiting, as I said, the intake of your salt. Sometimes they will prescribe you diuretics to reduce the amount of fluid in you, and that would decrease the amount of plasma, and therefore would give you a reduced blood pressure, right? And also sympathetic inhibitors, which will lead to hopefully your arterioles dilating a little more often and reducing the peripheral resistance, which would, of course, reduce your blood pressure. Venous blood flow. Blood pressure decreases as the blood moves through the arterial system and through the capillary bed. We saw that chart, right, with that big gap on the left side, and gets smaller and lower. The gap gets smaller as we move towards the right, and lower. There's a lot less pressure. When we finally get to the veins, right, the movement of blood in there is only partly a result of the pressure from the heart and the actions of the heart. The other things that contribute to the movement of blood through your veins is skeletal muscle contraction, right? If you look at that great picture, and I love that picture here, you have blood moving through the vein, and when the skeletal muscles contract, they squeeze, because they get thicker, up against your veins, and that's going to push the blood up towards the heart and open the valve. And then when it relaxes, the valves will close so you don't have backflow. We also change the pressure in the thoracic cavity as we breathe, and that's also going to help us contract and move muscles during that process, and we're going to move blood along that way. And there's also, as we mentioned before, though less, we still have smooth muscle in the walls of the veins, right? And when they constrict, that's going to help us move blood through. So, central venous pressure. So all the veins, except for the ones that are coming back from the pulmonary circuit, that is going to dump into the left atria, right? So the superior vena cava and inferior vena cava and the coronary sinuses are all going to dump into the right atrium. The pressure in the right atrium is called the central venous pressure. Factors that influence this can alter the blood flow into the right atrium. So if it's, if the pressure is not appropriate, we can have some problems. It can, when this alters, or whatever level it is, it affects pressure within the peripheral veins, right? So the movement of blood in that area is going to get affected by venous pressure. Weakly beating heart increases the CVP, or central venous pressure. An increase in that central venous pressure causes the blood to back up into the peripheral veins, right? So we don't have that, if the pressure goes up, we're pushing blood in the opposite direction, because there's not a lot of, remember, overall blood pressure force to move it forward. We rely on those things like muscle contraction, right? And the veins constricting to move it forward. So if the pressure in the right atria is high, we can push blood backwards, and that's not good. If that happens, we can lead to something called peripheral edema, right? The tissues around the veins or in the venules, right, will back up, the blood will back up, and liquid will go into the tissues, and that would be called edema, right? Edema is when we have excessive amount of fluid in the tissues. Increased blood volume or vasoconstriction increases blood flow to the right atrium, right, which increases your central venous pressure. right? So if we increase blood volume or vasoconstriction, we're going to jack up the central venous pressure. Moving on to exercise in the cardiovascular system. Exercise is good for the heart, but it has to be something. You can't just do, okay, you know what? I'm going to do 1 week of really good exercise, and then that'll be it for the year, right? It has to be a lifelong situation. Plus, you're going to have to teach your cardiovascular system that you're doing this, and so the system is going to have to adapt to this aerobic exercise. When it does, right, what you can do is increase the pumping efficiency of your heart, the blood volume coming out. Hemoglobin concentration, we're going to increase the amount of hemoglobin and red blood cells, right? And increase the number of mitochondria in our muscles, right? Especially in our heart to pump this blood. Mitochondria produces energy, and if we're being, using our body a lot, we're going to increase the number of mitochondria in our body. The heart might actually increase in size if you exercise enough to 40% in size, bigger. Stroke volume, right? Resting stroke volume will increase if you are athletic. Heart and blood pressure will decrease. To get overall benefit to your cardiovascular system by exercising, you need to increase your heart rate to about 70 to 85% of the maximum you can achieve. And there's the equation. You take 220 minus your present age. And that's the heart rate you want to hit. And you must do it for 30 to 60 minutes to, maintain that heart rate. So, going on a treadmill, all that sort of stuff is the usual way people do it, or go for a jog. And you have to do it 3 to 4 times a week. I know everybody here has 4 60-minute blocks that they can take out to just go jogging, right? The path of circulation, right? This is something we just covered at the start of this chapter, but to remind you, we have 2 different pathways. We have the pulmonary circuit that's going to take blood from the deoxygenated blood from the right side of the heart and carry it out to the lungs and carry oxygenated blood to the left side. That's the pulmonary circuit. The systemic circuit is going to carry blood, oxygenated blood, out of the heart to the body, right, to the tissues of the body, and then carry it back to the right side in a deoxygenated form, right? And it will go back through the circuit again. So the pulmonary circuit, the actual pathway is from the right ventricle to the pulmonary trunk through the pulmonary valve. The right and left pulmonary. Okay, so the pulmonary trunk is going to split. Right, it goes up just a little bit, and then it splits into the right and left pulmonary arteries. The right pulmonary artery goes to the right lung. The left pulmonary artery goes to the left lung. Then it goes into branches when we reach these lungs and get into divisions and divisions. And we get down to the pulmonary arterioles and then the pulmonary capillaries. And at the capillary level is where we do the exchange of gases. Then we start coming out the other end with the pulmonary venules, then the pulmonary veins. And the pulmonary veins carry the oxygenated blood back to the left atrium. Blood in the pulmonary arteries have low oxygen levels and high in CO2. Blood in the pulmonary venules and veins are rich in oxygen and low in carbon dioxide. The exchange happens in the capillaries, like I said. The systemic circuit is going to carry rich oxygenated blood from the left atrium to the right, from the left atrium to the left ventricle. And then when the left ventricle contracts, it's going to send the blood through the systemic circuit. I just want to make a point here, by the way. One way you can tell which ventricle you're looking at, if you see both of them, the one with the thick muscle wall is the left ventricle because it's the one that sends it the furthest, right, through the systemic circuit. The left ventricle is going to contract and send it into the aorta, all the arteries and arterioles leading to body tissues. The systemic capillaries are where we do the exchanges that we've already gone through. And then after that, we have the systemic venules going to the systemic veins and back to the right atrium. Here's just a look at the alveolar wall. The alveolar wall is the little pockets, right, where we do gases, sometimes called air sacs in the lungs. So high osmotic pressure in the interstitial wall is going to draw water out of the alveoli. That's kind of like the big point here. If you look at the wall, at the lungs, you don't want the you know, if you look at the center there, it says alveolar air. That's where the air is. That's your air, the alveolar is the air sac. But we want air to come down here to do the exchange, but we don't want it to fill with fluid at all. That would be called pneumonia. We don't want pneumonia, right? We want the tissue surface there to be moist, but we don't want it to be pooling fluid. So if you see there at 1, there's a site net flow of fluid from the capillary into the tissue that's creating the alveolar wall. Solutes are going to fail to enter the alveoli, right? But contribute to the osmotic pressure of the interstitial fluid. So what happens is that we're going to have things dissolved in the water that go into the wall, but don't go in past the wall into the air sac area. So when water actually goes and enters the surface, the osmotic pressure, because we have these solutes in the tissue fluid and the interstitial fluid, is going to bring back the water and just keep the surface moist, because it's not going to pool, because the osmotic pressure is going to cause the water to come back by diffusion. So any excessive water in the alveolus is drawn out by the high osmotic pressure of the interstitial fluid. Remember, that's the extracellular fluid around the cells. And there you go. That's the big point there. So we don't get pneumonia automatically because of the pressure of the capillaries pushing water out. The solutes bring the water back by osmotic pressure, not only back into the capillary at the end of the capillary bed, but also from the wall of the air sac into the interstitial fluid. The arterial system, I'm going to look at the overall. This is where we're entering road mapping, right? We're going to be talking about this is here, this is here, this is here, this is here. Some of this is going to just take your time sitting there and observing it and studying it straightforward. The start of your artery system, right, the systemic artery system, is your aorta. It's your largest artery in your body, and we're going to see how wonderful it is in a moment. And it supplies blood to all the other systemic arteries. This is actually, if you look on the side portion of the aorta, you have the ascending aorta, right, as it comes out of the left ventricle, the arch of the aorta, that curve that happens at the top of the aorta, and then we have a long tube coming down through the mid area of your thoracic and the top of your abdominal region, and that's the descending aorta. The ascending aorta, right after we get out, has only 2 things coming off of it, and that's the right and left coronary arteries. Remember, we talked about the coronary arteries. They're going to turn around and feed blood to your heart. You're going to feed rich oxygenated blood and nutrients to your heart, so you keep on pumping your blood to deliver the rest of it to the tissues, right? The rest of that oxygen and nutrients. The aortic arch is going to have the brachiocephalic trunk that's going to go up, and it's going to have things branch off of that. We'll see that in the picture where what branches off the brachiocephalic trunk. But you also have the left common carotid artery, which is going to go up the left side of the head, and the left subclavian artery going to the left upper limb. But that's also going to have some branches that are going to go up through the neck and a little bit into the thoracic region. The descending aorta, right? You have the sometimes called the thoracic aorta. You have the bronchial artery or the pericardial artery, right? And you can see them, so they're going to go off to different areas. You can see where they specifically go to the right of this. But let's take a look at the picture. So first, major vessels associated with the heart. Let's take a look at the arteries. Remember, the colors are not whether they're arteries and veins. The color is whether the blood is oxygenated or deoxygenated. The red is oxygenated blood. The blue is deoxygenated blood. So when we see in this picture the fact that the middle, that red thick pipe coming out in the middle of the picture, that is the aorta, right? And we have the ascending aorta, that's the part going up, then the aortic arch where we turn. I already mentioned that coming off that is the brachiocephalic trunk. You can see that that's the first thing that's in the picture that comes off of it. And we're going to have that split into the common carotid artery and the right subclavian artery. The right subclavian artery is going to go service, it's going to have branches that go off and service the neck and a little bit of the head. and also go down the right arm. We go a little further along past the brachiocephalic trunk, and we see the common carotid artery go up the left side, the left common carotid artery, and then we hit the left subclavian artery, and that's also going to have branches that go up the neck and also go off to the left arm. The next artery that I'm going to emphasize here is if you look at the pulmonary trunk, right? So right underneath the aorta that's curving, you see that blue area, the pulmonary trunk. It's you could probably call it an artery, though it's not by name an artery. It splits into the left pulmonary artery and the right pulmonary artery. It's blue in the picture because it's carrying deoxygenated blood to the lungs. Everybody good with that? Okay. What else do I want to emphasize while we have this picture up? Well, you can see the superior vena cava coming down and feeding into the right atria. And you can see the right subclavian vein. You'll notice the pattern here that, like if we have a right subclavian artery, we're going to probably have a right subclavian vein coming back, right? Okay. Major branches of the abdominal aorta. This is, again, more sitting there and studying it, but you can see the fact that we have branches. The splenic artery, the celiac artery, the abdominal aorta is that big branch coming down in that X-ray picture, that big thick one. And then we have things coming off of it, right, that are feeding different regions. Like the hepatic artery is going to service what? The liver. Whenever you hear the word hepatic, you're thinking liver. When you hear renal, you think kidney. So the renal artery is going to service the kidneys, right? Then we have intestinal branches, the superior mesenteric artery and the branches from the inferior mesenteric arteries. And this is going to serve as connective tissue around the intestinal, small intestines mostly. And then when we get to the bottom, and we're going to see more of this in the coming slide, we have the common iliac artery. And that's where the end of the abdominal aorta happens. So up here, arteries to the brain, head, and neck. You have the subclavian vein and the common carotid artery, and both are going to supply branches, right? The common carotid is mostly just going directly up there, but the subclavian supplies branches that are going up to the brain, the head, and the neck. You can see that in the picture. So there's this weird, interesting thing called the circle of Willis, or the cerebral arterial circle. This is a way of your brain backing up itself so that it has it's a backup to having sure that it gets a blood supply. We have two things going up there, the carotid artery and the vertebral artery systems. And then they fuse together into a circle, right? Called the circle of Willis. And that's done because if one of these become clogged or have a problem, you can still feed your brain because the other one is going to take over the job and supply blood to the blood vessels where the blood vessels of the brain that were being serviced by the one that became injured, right? So we have this kind of like backup system to each other, having the circle of Willis where the blood can go, okay, so we don't have blood being serviced, going to the carotid area. The carotid artery system is no longer working correctly and the blood is not going to the area in the brain serviced by it. The vertebral artery system can use the circle of Willis to push blood into that area of the brain. The subclavian artery is going to give off branches that go up into the neck, but it then continues down into the arm. Subclavian, I always think of mostly about the arm, but it does send up portions into the brain. And you can see some of the, well, we'll get into it in a moment. Blood is going to reach the thoracic wall, right? The wall of your thoracic region, right? Chest region, by branching off of several main arteries, like the subclavian artery. I also mentioned that services the thoracic region, and something called the thoracic aorta, right? The aorta, descending aorta in the thoracic region is going to send off branches that go and service that area. Finally, when we get to the bottom of the abdominal aorta, right, we're going to divide it into the common iliac arteries, which is going to supply blood to our lower limbs and our pelvic region, our glute region, our butt. Okay, the common iliac artery divides into two subtypes, right? We're going to have the internal iliac artery and the external iliac artery. The internal iliac artery is going to supply blood to our pelvic region and our glutes, right? Our gluteus maximus and gluteus minimus and all that sort of stuff, our gluteal region. While the external iliac artery is going to service our legs, our lower limbs. Before we go into the vein, I just want to mention another artery that comes up now and then. You can see on the inside, a little more the inside, the femoral artery of the thigh. The femoral artery of the thigh is a artery that goes down and supplies blood to the lower leg. And it's also an area medically where people will sometimes try to do blood samples from. I was a phlebotomist for a summer, and I would collect blood, and when now and then I didn't get the hit right away, you had a particular patient that would go, "Oh, just get the doctor to do it," right? Well, a doctor would have not done as many sticks as I had done, will come in, miss it like I did, and then order a femoral stick. A femoral stick is when they come in and collect blood from the femoral artery, right? And it's much more painful than a stick into your arm to try to find, your radial artery or something like that. Okay, the venous system. This is going to be, the systemic venous system is going to return our deoxygenated blood. By the way, deoxygenated blood still has a lot of oxygen, and it's just less oxygen than in the oxygenated blood, right? After we exchange gases and nutrients with the tissues in the capillary beds. Vessels in the nervous system is going to emerge from the capillaries into the venules and then become small veins and then larger veins. So unlike the arterial pathway, sometimes it's difficult to follow where the veins are because they're not laid out as strictly during development as it is with the arteries, because they're not, providing a particular pathway and having to deal with force and be lined up so correctly. They can be a little more haphazard on how they're laid out, as long as they get their material back to the heart in the correct way. Most of the large ones you can find fairly easily, right? But the venules and so forth can be a little more haphazardly placed. And they might have a few extra ones or a few less and so forth. As it says there, pathways of the larger veins usually parallel the same areas of the arteries and have usually the same name, like the subclavian artery is going to be near the subclavian vein. There you go. And do more or less, return blood in the same manner. All the systemic veins are going to converge eventually to the superior and inferior vena cava, which is going to dump their deoxygenated blood into the right atrium. The external jugular veins are going to drain blood from the face, scalp, and superficial area of the neck, right? The internal jugular veins is going to drain blood from the deeper areas of the face and neck and the brain. Veins of the upper limbs of the shoulder, right? Here we're servicing with the subclavian vein again. The deep set of veins are going to go from the digital veins through the radial and ulnar veins to the brachial veins. The superficial set of veins, right? Anastomosis is basically when blood vessels kind of fuse. So there's kind of like this kind of, not capillary level, but kind of a little bit larger network of blood vessels that fuse and pass blood back and forth. And this is going to, in the pulmonary, pass blood eventually to the basilic and the cephalic veins, and eventually going to the basilic vein joins the brachial vein, and the cephalic veins will join the axillary vein, and that's going to carry blood back. Okay. Veins of the abdominal and thoracic wall. The abdominal and thoracic walls are going to drain by tributaries in the brachiocephalic and the aziogos veins, and that's going to carry it back into the superior vena cava. Now we're going to address something, veins of the abdominal viscera. And more of them are going, carry blood normally back to, something that's going to lead to the superior and inferior vena cava. But there are veins called portal veins, and they're unusual in that they do not directly transport blood to the heart. They're going to transport blood to another capillary bed. So it's going to come out of a capillary bed and go to another capillary bed. And the two big areas are going to be the hepatic portal system, right, where the veins are going to carry blood to basically the capillary bed in the liver, right? And then there's going to be an equivalent one in the kidneys, and that will be a renal hepatic portal system. So here we explain, the slide explains the fact that the blood from the capillaries in the stomach, intestine, the pancreas, and spleen eventually go into the hepatic portal vein, which is going to transport it to the liver, the capillaries in the liver, right, to be processed, right? We're going to have some chemical metabolic reactions going on here. And then it goes on into a new vein and carried to the inferior vena cava. Here's just a schematic of the portal systems, and you can see the hepatic portal system there. And that's the one with like the 3 capillary beds and the pipes coming out, going to the liver capillaries there. That's the hepatic one. And then right below it, you'll see the renal equivalent. Veins of the lower limb of pelvis, blood from the lower limbs are going to drain into the deeper and the superficial groups of veins that carry up to the back to the heart. The deep vein system is going to be coming from the veins in the foot and going to the arteria and posterior tibial veins, named after the bone, the tibia. And the popliteal vein goes into the femoral vein and then to the external iliac vein. The superficial veins, a set of veins, are going to go from the veins in the foot to the small and great saphenous veins. The great saphenous vein is the longest vein in the body. There you go. New trivia for you. Okay, we're getting close to the end. Some molecular causes of cardiovascular disease, right? So you can have environmental problems, right? Things in your environment are going to cause you to have cardiac problems, develop cardiac disease. You might have hereditary factors. Usually it's a combination of both, right? They're going to lead to cardiovascular disease. Marfan syndrome, right, is a birth defect. You have a connective tissue defect. You're not producing, you're producing a weird type of fibrillin, right, which is a protein. When you produce this, you're not going to have your walls of your aorta be strong. It's going to weaken the walls, and you can end up with an aneurysm and have your aorta burst and just suddenly die. Familial hypertrophic cardiomyopathy, which is a deficient in the myosin. It's a myosin defect, right? What happens here is that you inherit an overgrowth of the myocardium. You have an abnormal amount of cardiac tissue there, caused by abnormal myosin chains in the cardiac muscle, and it can lead to sudden death. Inherited deficiency in the mitochondrial enzyme that breaks down fatty acids. So the heart needs energy again and again and again. And it says there, cardiac muscles is going to use these fatty acids, these long-chain fatty acids, as its primary energy source. Interesting enough, remember when we talked about the brain uses glucose, direct glucose, as its primary energy source. Here, cardiac muscle is going to use long-chain fatty acids as its primary energy source. But heart failure results from the inability to break down these long chains to get the energy we need, right? And then you have familial hypercholesterolemia, abnormal low density lipoprotein receptors on the liver cells so you have low ADL receptors on those liver cells, and they do not take up cholesterol from the blood. So we have more and more cholesterol circulating in the blood, leading to cholestasis. Coronary artery disease, or CAD, right? It's a disease involving the depositing of cholesterol plaques on the inner level of the coronary artery. Remember, the coronary arteries are feeding your heart. They are there to provide oxygenated blood and give all that great oxygen and nutrients to your tissues, right, of your heart. It's when you have this increased depositing of cholesterol is going to lead to an obstruction of the coronary arteries, and so your heart gets less O2 in its muscles, and therefore is not going to have enough energy to do the job as well as normal. Often accompanied by high serum cholesterol and hypertension. It's going to lead to high blood pressure because you have these kind of obstructions, these blocks in your systemic artery circuit. Often cause chest pain upon exertion, called angina pectoris, right? Pectoris is, the chest region. So you have an angina pectoris event. This is one of the things that can lead to myocardial infarction, right? Which is going to be a heart attack. Your heart is going to be deprived of oxygen and suffer an infarction. Treatment can be coronary bypass surgery. That's an extreme situation. Or you can use angioplasty, right? Where you send that's the thing that goes up with a, coronary bypass is you add a new pathway, right? You just surgically sew it in to do it. Here you put a balloon up in there and you puff it up to basically clear up the area so that you can have more passage of blood. Lifespan changes. Cholesterol depositing in the blood vessels as you get older is going to become more common. You can have narrowed coronary arteries just because of everything I just said in the last slide. Your heart might shrink slightly or enlarge due to disease, right? So your environment might change the size of your heart. The proportion of your heart consisting of cardiac muscle declines. So the ability to generate a lot of force, right, as it normally did when you were 30, goes down. Now, it's usually good enough, right, to keep the heart moving, but you might suffer some problems if you try to overexert yourself when you're really old. Right? Increase in fibrous connections, connective tissue in the heart. That's going to stimulate a little more rigidity in the heart, right, than you probably want. Increase in adipose tissue in the heart. Some of the tissue is going to have more fat deposit around it. Heart valves and the left ventricular wall may thicken just because of use, right? Remember, the left ventricular wall has has the highest amount of cardiac muscle, right? Because that's ascended. And if it keeps on beating again and again, it might thicken over use, right? The heart valves might thicken, and that could lead to certain particular types of problems. Increased systolic blood pressure, right? If your left ventricular wall increases because of muscle accumulating in that area, your blood pressure will increase when it contracts because you have more force. Decreased resting heart rate. So when you're relaxed, your heart rate might be basically lower than what was true when you were 30, let's say. Lumens, remember the passageway, the hollow area of the pipe, right, is the lumen. The lumen of the large arteries might narrow as the arterial walls thicken. The walls of the